use of modified constraint induced movement therapy for children with cerebral palsy by Allison Grover, Rebecca Jarrett, and Victoria McCluskey. The clinical scenario is Bradley is a 5-year-old Caucasian boy with right side hemiplegia resulting from cerebral palsy. He is able to walk independently while wearing AFOs on both of his lower extremities. He has limited right upper extremity functions. He was referred to occupational therapy for decreased strength and decreased use of his right upper extremity. Bradley lives with his parents and 2 siblings who are 8 and 10 years old in Charlotte, North Carolina. His parents hope to see him become more independent in his activities of daily living and have recently come across modified constraint-induced movement therapy. Bradley's parents have questions regarding the effectiveness of modified constraint-induced movement therapy. His parents are open to suggestions regarding the use of modified constraint movement therapy for more beneficial results from occupational therapy.
The evidence-based practice question was, for a 5-year-old boy with hemiplegia resulting from cerebral palsy, is modified constraint-induced movement therapy effective in improving strength and use of the right upper extremity for the ability to complete activities of daily living? After developing the PICO components and keywords, the search terms that were used varied by each database. For the Cochrane Library, the search terms used were constraint-induced movement therapy and cerebral palsy. For Medline, we searched modified constraint-induced movement therapy or constraint-induced movement therapy and children with cerebral palsy. For OT search, we searched mCIMT. For Pedro, we searched modified constraint-induced movement therapy and cerebral palsy.
The articles that are included in this best bet are, the inclusion criteria are peer-reviewed articles, evidence levels 1, 2, and 3, children ages birth to 21 with hemiplegic cerebral palsy participating in modified constraint-induced movement therapy or constraint-induced movement therapy, and children with hemiplegic cerebral palsy participating in modified constraint-induced movement therapy and bimanual training. The exclusion criteria are evidence levels 4 and 5, qualitative research studies, and studies that compare constraint-induced movement therapy to bimanual therapy.
There are 6 studies that were appraised, which are all level 1 evidence, and they were appraised for improving the strength and use of the upper extremity in children with hemiplegic cerebral palsy through the use of modified constraint-induced movement therapy. Overall, the results supported the use of modified constraint-induced movement therapy to improve function of the upper extremity when treating children with hemiplegic cerebral palsy, and the evidence suggests that modified constraint-induced movement therapy is an effective intervention for children with hemiplegic cerebral palsy. However, 2 of the studies within a systematic review did not conclude positive results. The authors suggested that these results be viewed with caution, considering the lack of methodology and inaccurate reportings. One of the randomized control trials that was appraised also supported the use of modified constraint-induced movement therapy and displayed significant improvement. However, their results cannot be generalized to other children with cerebral palsy due to the small sample size within their study. The first theme of our appraisal was the benefits of implementing modified constraint-induced movement therapy with bimanual training. 2 studies addressed the effectiveness of modified constraint-induced movement therapy in children with hemiplegic CP with the additional use of bimanual training. The efficacy of the combination of modified constraint-induced movement therapy and bimanual training is strongly supported by current evidence. These articles' results found that modified constraint-induced movement therapy followed by bimanual training had clinically significant results and is an effective intervention approach to improve the use and function of the more affected upper extremity in children with cerebral palsy.
Many of the studies had various duration and intensity of the intervention. One of the systematic reviews conducted that intensive intervention had more significant treatment effects than non-intensive therapy. However, another systematic review did not find any improved outcomes with an intensive treatment protocol. The consideration for duration frequency varied among studies. One study resulted suggests that modified constraint movement therapy for 4 weeks duration is effective in improving upper limb functions in children with CP. One study found effective results for completion of modified constraint movement therapy and bimanual training for 3 days per week for 8 weeks. A clinical practice guideline recommends that a combination of modified constraint-induced movement therapy followed by bimanual training be conducted for a minimum of 48 to 63 hours throughout the intervention period to receive clinically significant results. This clinical practice guideline reports that there is higher level evidence to support this recommended number of hours than the evidence supporting a few number of hours. Several of the articles suggest future research to determine the optimal frequency, duration, and/or intensity of the use of constraint-induced movement therapy in children with hemiplegic CP.
Many of the studies have addressed the effectiveness of modified constraint-induced movement therapy on improving one's ability to successfully complete activities of daily living. One study conducted a randomized control trial using an activities-based approach. Through this study, it was found that focusing on participation in ADLs instead of focusing on their impairment helped individuals increase their learned use of their affected extremity. In addition, a randomized control trial used intervention sessions that disguise dressing, eating, and drinking by making them pirate-themed. By disguising these tasks, the participants' desire to complete them increased. One study looked at the effects of modified constraint-induced movement therapy on improving hand dexterity and strength in order to successfully complete ADLs. Although it was found that additional research needs to be completed on this topic, this initial research supports the use of modified constraint-induced movement therapy in improving strength and functional use of the affected extremity to complete ADLs.
The majority of the studies preferred a more natural treatment environment. Benefits for natural treatment environments are that they can be less distracting for the children and parents, they can easily fit into a family's daily schedule, they're cost efficient, and that implementing CIMT in a natural setting such as the home or school would significantly reduce costs associated with treatments. It also allows parents to be more involved and confident in their child's treatment. It is also encouraging parent-child interactions, and it can aid in compliance of interventions. Limitations for natural treatment environments is that it can also disrupt family life, and treatment would be more controlled in a clinic setting with an OT.
The clinical bottom line regarding modified constraint-induced movement therapy for a child with cerebral palsy is that the research suggests the use of modified constraint-induced movement therapy in improving strength and overall upper extremity function for children with hemiplegic cerebral palsy. It helps effectively complete ADLs, and parents and children prefer a natural setting to complete modified constraint-induced movement therapy. Through this search, it was found that the combination of bimanual therapy with modified constraint-induced movement therapy could be a beneficial option to explore to increase upper extremity function in children with hemiplegic cerebral palsy. Studies of praise provide evidence to answer the evidence-based practice question and to guide future intervention plans for a 5-year-old boy with hemiplegic cerebral palsy.